I don't mind. You could have your face in, Sandra, if you like. I see Susan. Oh, every time I try and click on her name to bring her in, the chat moves, the list moves. Hello, everyone. I'm just trying to bring our speaker into the. Oh, okay. I'm going to leave it a minute until people stop entering. The people trying to click on you, Susan, and it moves down to someone else's. I think I've done it. I think I've done it. Oh, am I promoting the right person? Oh, I don't know now. Okay. Ooh, I hope that's the wrong person.
Yes.
Yes, it is. Here we go. Hooray!
Good to see you.
Good to see you.
I was trying to join as a panelist, so I sent off a quick email to Tia letting her know.
Oh, okay.
Apologies, not to retract.
Yeah. Oh, okay. Yeah. Do you want to message Tia and just say that's fine? We've got Susan in.
Thank you so much.
Otherwise, Tia will appear in the room, I suspect.
That's what I was like, oh no, I was a bit too quick. I was trying to sign in with my work email and it wouldn't let me.
Oh, okay. Oh, we got you here. I spotted you on the list. Just
Well done. I'm gonna go ahead and see about sharing screen because I'm hoping to be able to share my slides and presenter view if it will allow me. If not, I have my notes up on a separate screen. I'll just be looking like this most of the presentation.
Yeah, no, I should be able to let you share the screen.
Yeah, I think it's an option. I just have not done it as an advanced. Oops. Where'd it go? Okay. It just says disabled participant screen sharing.
Let me just, I thought I had just enabled it, but it is, no, I hadn't. I'm winning. Host and panelists, that would work better, wouldn't it? There we go.
Thank you.
You all set with keywords and things, Susan? Because
yes, I have those all built in. Exactly.
So I'll wait another. Well, actually, it is now time, isn't it? So I'll just get everybody on board, and I'll just go through in case anyone's not been to a talk yet that's got CUs. I'll just talk a little bit about that. And then I'll hand over to you, Susan. Okay. So welcome everybody. Hope you've enjoyed your lunch if you're in for the full day's conference. This is a CEU talk. I'm losing the ability to speak today. The process for accessing those CEUs, I'll put a link in the chat. There's also a QR code that we can show at the end if people prefer to access it through there. It takes you to a magical screen that looks a little bit like this, if anyone can see it. And on there you type in the amount of money, which is £8, and you then need to put in the 2 keywords, which Susan will be giving us, which are Disney themed, spoiler alert. And also make sure you put your email address. Really important. If you do not put your email address, we will not be able to get your CEUs to you. So really important that you put that email address there. I think that's most of the sort of admin stuff. Remember that we were also raising money for the Bobby, for the Newman Trust holidays. So we'll put that link in the chat as well if people would like to donate. The holidays cost about £8 to put on each holiday. So we'd really love to make at least a chunk out of one of those holidays for them. I can see we're getting lots of people in, Susan, so that's absolutely fab. Thank you so much for coming in and talking to us. Me and Sandra, who have been doing a lot of work with the families as well, are really looking forward to hearing all about this too. So we'll be in the background monitoring the chat. If people have questions, please use the question and answer feature. It just makes it a lot easier for us to spot when you're asking questions. And we'll have hopefully a bit of time at the end, Susan, to field those.
Yes, definitely.
I've done everything. Fantastic. Over to you then, Susan. Thank you very much.
Thank you. And this little bit of housekeeping, you can see my presentation okay, but nothing as far as the notes. All right.
It's showing perfectly for us. Yes.
I've mastered advanced features on Zoom screen sharing. Look at that. It's a new skill.
Mention the chat's disabled, so I will enable the chat as well when Susan starts talking.
Perfect. Thank you so much for having me. It's an honor to be invited back again. This is my second year presenting at the PBS Good Practice Conference. And today I'm going to be talking about a PBS approach to engaging trauma experienced parents. Just a little bit about myself. Like I've mentioned, my name is Susan Tirella. I'm a board certified behavior analyst, licensed in the States as well as UK, BA certified here in the UK. You can tell from my accent that I'm not originally from here. I am American, but I've lived and worked in the UK on and off since 2016. In addition to being a behavior analyst, I am also a doctoral student in psychology. And I'm working as the clinical lead at Positive Support Group. So we're a community-based PBS company. We support children, young people, and adults who engage in pretty severe, risky behaviors of concern that impact their placement stability. So we work a lot with people who are at risk of hospitalization or who are stepping down and returning back into their homes or into their community settings. And we do also a lot of work with school refusers and trying to support children and young people to access education. As far as today goes, as far as our learning objectives are, we're going to be taking a very compassionate but PBS approach to supporting families who have experienced trauma. So therefore, the learning objectives are very much outlined like we would do our assessment, intervention, and outcomes. So the very first thing we want to do is we want to define the behavior. So we're going to be defining trauma. We want to understand its prevalence, specifically with parents of autistic children or those with intellectual disabilities. I think it's important to have those statistics in our heads when we're walking into a family's home. And we'll start to pinpoint some specific trauma symptoms, so that way you guys can know how to potentially pick up on experiences of trauma if you're not aware of them when you're walking in and meeting a family for the first time. We'll be talking about some of the literature on assessments, talking about formal assessments, as well as more informal assessment tools. And then when it comes to intervention, we'll be describing compassionate parental support. We'll take very much an acceptance and commitment therapy lens, but we'll be pulling in some other different research elements. And then finally, we'll be talking about outcomes. We have a case study that of one of our clients that we've supported. And then we'll also be talking about some of our outcomes data and how we monitor outcomes for some of our families. Just as far as terminology goes, I think it's good to have a little bit of a disclaimer that I'm going to be using certain terms in the presentation that I wanted to just take a moment to clarify. I think the very first thing is we are talking about trauma, so that can be triggering for some of the people on the call. We know that this is difficult, especially because we're going to be talking about trauma from the parent's perspective. And as clinicians, behavior analysts, whatever your background is, we do always take a client-centered approach. And we want to make sure that we continue to put the client and the individual at the center of all of our decision-making, but that doesn't mean that we neglect the families and any potential trauma that they may be experiencing. And it's actually pretty key to mediator engagement and bringing a family along to really be mindful of where they're coming from, how their trauma can impact their not just willingness, but their actual ability to engage with our service and with our recommendations. So I think it's important to remember our client is still at the center of our intervention, but we are still learning about how trauma has impacted the family and those around them. Other terms I'm going to be using, I interchangeably, when I'm presenting to a large audience like this, I'll interchangeably use terms autistic people as well as people first language, like people diagnosed with autism, children with autism. I use it interchangeably intentionally when I'm presenting because it's important for us to be mindful that there are different ways of talking about autistic people, and we always want to be using the language that that person wants us to use. So I use them interchangeably, and I will throughout the presentation. Doesn't mean to offend anybody. It's intentionally flexible. In addition, I'm going to be talking about terms like learning disability and intellectual disability interchangeably just for the sake of this presentation. In the UK, we tend to use the term learning disability when we're talking about this population of individuals we support. In a lot of the research, though, they use the term intellectual disability. So I just wanted to clarify that. And the final term I just wanted to highlight is we're going to be talking a lot about resilience. And I think some of us come from a perspective that resilience is a really positive thing that we want to foster and kind of bolster in those that we support. There is sometimes, though, a negative connotation. I've actually worked with some families when they hear that term, they kind of get their back up and they get a bit defensive, and they sometimes feel a bit judged. So I think that's something that we just want to be mindful of our audience. So we will be using that term throughout the this talk, mostly because that's the term that's in the literature. And this is for CEUs. We are going to be citing the research when we're talking about trauma and post-traumatic growth and things like that. But when we are parent facing and family facing, just again, I think we're really good about being mindful of our language. And so it might be something that could be a challenge for some families. As mentioned, for those of you who are looking for CEUs, we do have our sign-in code. So our sign-in code, I love the Disney theme, is Lilo. So think Lilo and Stitch. Please jot this down. At the end of the presentation, I'll pull up a similar slide with the sign out code, and then the ladies will prompt you with how to access that through the form, and there's a QR code as they mentioned. Okay. So the first thing we're going to do is we're going to be defining trauma. And so it's important to remember that trauma isn't defined by the event, but by our reaction to it. The consequences of the experience have long-term effects, and they serve as really a motivating operation for future contingencies. So Richter, Levine, and Sandy in 2021 defined different levels and different experiences as far as arousing experiences, stressful experiences, all the way up to traumatic experience. And they're proposing this more as a conceptual distinction. And I think it's really important to make sure that when we're talking about trauma, we're really understanding what the severity is. It isn't to minimize other experiences that are arousing or stressful. But when we're talking about trauma, there's really long-term physiological, like biochemical changes that we need to just be more aware of. So the first term they defined were arousing experiences. These are experiences that activate a detectable emotional reaction, and they also affect our choice and the way we respond in the moment, but they aren't going to lead to long-term changes in our physiology. They aren't going to lead to long-term changes in our behavior. So an example is I may be walking home from the tube, I may step off the curb, and then I pause and take a step back because a bus might be going very quickly by me. I'm going to have an arousing experience. My heart rate's going to start to increase. I might sweat a little bit. I'm going to be shaky. For me, that might just be an arousing experience, though. It's not going to impact me the next time I'm walking home from the tube. I'm not going to be triggered. I'm not going to be anxious when I cross the street in the future. It's going to be, again, an arousing experience, but it might end at that point. Stressful experiences not only activate that immediate emotional response, but they also induce lasting alterations. So they are going to change potentially how we respond to future experiences that are similar. So stressful experiences are more intense than just an arousing one. However, they're not pathological. So we still are going to be able to cope for the most part with stressful experiences. And that's going to obviously depend on our own capacity and the degree to which we can adapt to future challenges, but it's not going to affect us as severely as traumatic experiences are. So if you think of these as a spectrum, you can imagine traumatic experiences are going to lead to that more robust emotional response in the moment. It not only acutely changes how we respond right then and there, but also long-term, it changes how we respond to future situations that are similar as far as contingencies. But trauma goes beyond that and actually is pathological in how it affects our bodies. It affects not only our behavior and our emotions, but there's a lot of research that talks about how trauma affects our biochemistry. It even can affect our DNA. And we're not going to go into the details of that. I love to geek out and talk about biopsychology, and that's kind of a special interest that I'm looking into myself more. But I think when we think about the environment and the internal environment as setting events and motivating operations for any behaviors, when we think about trauma, we have to consider the impact that it has on our biopsychology and on our physiology. So I know I talked about how trauma really is assessed by how we respond to it. But when we think about parents of children with autism or parents of children with a learning disability, they're going to be going through a number of different events in their life that could be potentially traumatic. And I apologize for, I think my graphic might have jumped ahead of me. So I admit I probably spend way too much time on TikTok. I probably shouldn't admit that to this large of an audience, but I do. It's a good coping strategy. It's a good way to turn my brain off and also maybe be a bit cooler around my teenage nieces. But there was this TikTok that was going around as also a meme that wound up to be fake news, but it stuck with me. And the whole idea was, if you're having a bad day, don't worry. There are people who are getting off the airplane in Austria thinking they were going to Australia. So it's not real. There is not a help desk for people in Austria who wound up on the wrong continent. But it just something to kind of put things in perspective. And there was this talk or this kind of short story that was going around years ago about how somebody who getting an autism diagnosis, or a parent who has a child who's getting an autism diagnosis, kind of steps off a plane and they're in China and they thought they were going to be somewhere else. It's not a bad thing. Austria and Australia, equally beautiful places, but it's unexpected. And that's something that is going to resonate with some families. There could be feelings of disappointment, and then there's going to be feelings of guilt. Like, why are they disappointed? Their child is still healthy. They might still be happy, but they still are going to be unsure potentially about how to parent this child. So there's going to be potentially a lot of feelings of inadequacy as well. So that's kind of like your starting point. So you're thinking about those arousal levels. You're already kind of starting to feel like a little bit of discomfort there when it comes to parenting. So we have the unexpected diagnosis. We also have numerous professionals who are going to be coming into their lives. And this is cited in the research that this is actually can be very stressful for families when they have all of these people coming in, but there's no clear roadmap. It's overwhelming. Who do they listen to? What do they prioritize? They go online and they read research and they get even more overwhelmed and maybe turned off to certain things. And so families can really start to get decision fatigue. And they may really have to focus on advocating for their child's rights and access to services. And that could be really, again, adding to their overall stress levels. Their child may have additional or unique learning needs. So they may need support with communication, their activities of daily living, their social skills. The family may not feel confident in parenting their child, and they're going to need that specialist support. And again, this is going to be compounding those feelings of inadequacy. On top of that, we know statistically, children who have a diagnosis of autism are more likely to have sleep issues. So that means their parents are not going to be sleeping as well. And that is going to be triggering more kind of like cognitive issues potentially. Children with intellectual disabilities, learning disabilities, and autism may have additional medical needs. So they may have special diets that are restrictive, that also might impose some level of financial hardship. They also may have to witness really evasive medical procedures, which, I've had to watch children on the spectrum go through a haircut, which was harrowing. I can't imagine having to support, things through like blood draws and all of that. And those are just basic care. Imagine, additional types of medical procedures that are needed. All of those things are just going to compound for those families. And then finally, a lot of the children that we work with engage in really risky behaviors of concern. So again, these families are going to have a difficult time supporting their children through this. They're going to feel judged. They're going to feel like they are maybe failing as a parent. And they also might be afraid, their child might be harming themselves. They might be harming their siblings, and they actually might be harming their parents. And I've worked with parents where they are fearful of their child. And it's important to keep that in mind when we are coaching and providing any type of like recommendations to implement specific strategies. Again, all of these things are going to be very unique to each family though. So trauma is going to be based on, how families respond to each of these different scenarios or situations, as well as how their own history has developed over time. As far as trauma prevalence goes, it's reported that more than 50% of parents of children with intellectual disabilities have highly elevated levels of interpersonal trauma. In addition, parents of children with autism specifically are reported to have 2.5 to 3 times more likely to demonstrate depressive symptoms. And that's compared not only to neurotypical children, but also to children with other different types of learning needs. So I think at baseline, our families are going to be coming in with more likely to have some type of experience with trauma. When we think about the impact of trauma, I think we automatically go to the negative impact, right? We think about the risk factor for mental health problems. So for example, post-traumatic stress disorder or PTSD, that's a negative, obviously, impact of experiencing trauma. But there's this other thing, and I think this is where I like to come from, is empowering us, right? We're behavior analysts for a reason. We want to be able to go in there and affect positive change and improve the quality of life for our clients and everybody around them. And so there's actually research to show that those who experience trauma, but then have support, they're reinforced for their coping skills, their social skills, they are more likely to actually have increased levels of resilience compared to people who have not experienced trauma. And this is something called post-traumatic growth. So it's really important to remember that, yes, we have to be mindful of not re-traumatizing families. We have to, come from a really compassionate place when we're supporting them, but we also can be empowered to show that we can actually increase our resilience and we can increase their coping skills. And there's evidence-based strategies that we can employ to do that. So before we talk about the actual interventions and the different ways that we can support families, I thought it'd be nice to talk about how we could actually more formally assess parent trauma. So now we've defined the behavior, we've talked about the prevalence, now we're going to go into our assessment stage. So there are actually quite a range of ways that you can assess trauma. The top 3 tools on this page I'll talk through, but these are all different ways that you can look at trauma symptoms. And then the bottom 3 are ways that you can look at symptoms or strategies related to resilience. So the first one we'll talk through is called the Parenting Trauma Checklist. Each of these are interview tools. This first one is a 17-item instrument. It assesses PTSD symptoms. It looks at global mental and physical health, lifetime trauma exposure, as well as any type of functional impairment. So it's a 17-item system. It's a Likert scale that you would use as an interview to ask families their experience with each of the different items, and then you can rate their level of trauma experience. This could be used initially as baseline, and then at the end of your intervention, you can see if you've potentially alleviated any of the different symptoms. The next one is the impact of event scale. This was originally published by Weiss and Marmon in 1997. It's then since been revised. This is a 22-item scale. It also assesses the overall severity of post-traumatic stress symptoms, and it looks at 3 distinct dimensions of it. It looks at intrusions, different types of intrusive thoughts and feelings, hyperarousal, so again, thinking about their physiology, as well as avoidance. Are they avoiding specific situations and scenarios? And also uses that 5-point Likert scale. And then the third one assesses rumination. So this is the event-related rumination scale. And this is something you'll see as a common theme within post-traumatic stress, where people will ruminate and kind of can't let go of a certain thought or feeling, whether it be an intrusive thought or something that they're more consciously thinking about. So this one actually measures both intrusive ruminations as well as more deliberate ones using that 4-point Likert scale. So each of those, like I said, those top 3 can be used to measure symptoms of stress and trauma. The bottom 3, again, are looking at more of the resilience measurements. So the post-traumatic growth inventory was developed in 2010. This is a 21-item inventory. It looks at potential positive changes that have occurred following a traumatic event. Again, they each are rated on a Likert scale. And they have 4 subscales. So that's looking at changes in self-perception, changes in interpersonal relationships, their appreciation for life, and also potentially any spiritual changes. These next 2 are ones that actually we are either starting to use or we have been using at Positive Support Group. So the Connor-Davidson Resilience Scale, or the CD-RISC, is one that we are actually starting to pilot with some of the services that we're providing that are specifically targeting resilience with families. So the CD-RISC has two options. There's a 25-item scale as well as a short version, which only has 10 items on it. Each item is rated on a scale of 0 to 5. And again, it supports the idea that resilience is malleable and can improve with time. And then finally, the Sheffield Learning Disability Outcome Measure, it's a bit of a mouthful, we call it the SLDOM. We don't, it's called the SLDOM. This is a tool that we've been using for quite some time at PSG, and it's not necessarily geared towards measuring specifically resilience and trauma. However, it does look at things like the parents rating their understanding of their child's behaviors of concern. They rate their ability to manage their child's behavior, their own coping skills, their feelings of failure, their confidence in working with support services. And it's something that we've been using for quite some time, pre-intervention, post-intervention, and it also has an option to do a 6-month follow-up. So it's really nice to see if the behavior change that we're able to support in the families is sustained over time. At the end of today's presentation, when we talk about some of our data and our outcomes, we'll be sharing some of the aggregate data that we have for our clients on the SLDOM. So these are just a few different formal assessments that I found within the research. There's other ones that you can look at, like the Parent Stress Index, I found is a very common one that you'll see. But it's really important to understand kind of the why. I can't do a presentation without quoting Simon Sinek. He always says, lead with why. So why do you need to do this assessment tool? And that's going to really be based on your workplace setting. It's going to be based on the family that you're working with. And you want to pick either a tool that is going to give you the information that is going to help inform the best possible support for them, or that's going to be able to measure the outcomes and the behaviors that you want to change throughout your intervention. And then for some, you're going to decide that these formal assessment tools are great, but they're not necessarily relevant to the work that we're doing. And then if that's the case, that's totally fine. What you can still do, though, is be mindful of any potential post-traumatic stress symptoms. So you can do more informal assessment. You already may be aware of fight, flight, freeze, and fawn. That's something that's very commonly discussed when you're talking about trauma, but these are some additional symptoms that you might observe as a response to traumatic stress. We've already talked a little bit about rumination. So that is when you're continually having those persistent thoughts and feelings that you can't necessarily let go of. Those could be intrusive ones that you can't necessarily control, as well as ones that you might be more intentionally, you're not always choosing to think about those things, but there may be more of a choice there. You're going to observe potentially some social or interpersonal impact. So people's sphere, their social sphere may shrink. They may not be as interested in interacting with others. They may have a negative self-perception. So they may either, talk poorly about themselves. They may, say things that they feel like they aren't able to cope. They're not able to implement any change. So there's that learned helplessness. And you might see an overall quality of life impact. So I've seen this with some of my families where their own personal hygiene is suffering. They're not able to necessarily, take care of their household as well. Maybe they're not engaging, like we talked about, in social interactions. But if you think again about that perma wheel and the different areas of quality of life, families may have poor quality of life. Regardless of if you're choosing to do formal assessment, informal assessment, or dive right in, you can always be sure to use some different strategies to compassionately support families. And really for today, we're going to be talking about how we can meet them where they are. And there's a few different ways that we can do that. The first thing is to take a compassionate approach. So there was a great article that actually just came out a few months ago by Penny et al. Called Compassion, the Eighth Dimension, which I'm a huge fan of. If you haven't had a chance to read it, highly recommend it. But here they talk about compassion being able to convert empathy into an act that's aimed at alleviating suffering. Compassion not only activates the reward sensors in the brain for us, and it's a helping component for empathy. it's actually been shown in the research that it's the most effective treatment in healthcare. So if you do nothing else, taking that compassionate approach to supporting families is critical. One of my favorite ways, though, to approach engaging a family is to adopt what's called the trans-theoretical model of behavior change, which I love. One, because I love, it's a mouthful. It sounds very, very smart to say, right? But it's a really wonderful way to think about where an individual is at within preparing for change. It's something that you'll see used a lot more in like habit reversal. You'll see it used when you're trying to treat like addictions. So you'll see research on it with decreasing smoking. You might see it with increasing medical or medication adherence, or even within like diet and weight loss. So those are some different examples of it. So we'll talk through this a little bit and how we can then relate it to where our families are at. I think it's important when we're thinking about this model of behavior change. I like it because it's not static and it's not something that is exhaustive. It doesn't necessarily, it's not like a blanket approach. So for example, the first stage is a pre-contemplation stage. This is basically the no, we're not ready for change. And this is where, you know, we want to really be respectful of a family and acknowledge they're not ready for change for that specific skill or that specific area or behavior. But that doesn't mean that they're not ready to change everything. So for example, I may not be ready to start working towards my goal of running for and doing like a marathon, but I might be open to be thinking about making changes in my diet or something like that if I'm wanting to try to get healthy and increase my healthy habits. We then see that families or individuals will move into the contemplation stage. So this is the maybe. This is when they're open to considering the benefits and the response effort. So this is where we can be supporting them to like weigh up the pros and cons of change, working on them, helping to identify the balance, talking about potential feelings of ambivalence and like why we should be working towards change. In the pre-contemplation stage, we could still be talking a little bit more about the risks, but when they're actually moving more towards contemplation, then we can start to talk about the benefits and start to increase their confidence in change. We then want to help to facilitate moving towards preparation. So this is what we call the yes, I am willing to plan and prepare. So this is where we're going to be activating some clear goal setting, helping them to engage in a realistic plan and taking those baby steps towards change. So if I'm going to be, you know, thinking about running a marathon, and my pre-contemplation, I like to think about this is Christmas Eve, Christmas Day. I'm like, no, I'm just going to enjoy Christmas. I'm going to enjoy my holiday. That seems like a January goal. I'm not even going to think about that right now. Contemplation usually happens around Boxing Day. We're like, ooh, we've overdone it a bit these past couple days. Maybe I should really start to think about, there's some really benefits. My friends are runners. I can get out there. I can build up some good habits again. Preparation is when we are, you know, either purchasing ourselves some new leggings, finding those running shoes from the bottom of the closet and getting them out and ready and setting that goal. It's typically the 2nd of January is when we decide that that's when we're going to be a runner again. And then action, this is where we actually are engaging. So whether we're engaging a family or we're engaging in our own habit change, this is the actual doing. So and this is where we are going to be continuing to support families. We may take on more of that behavioral skills training approach to modeling and coaching, providing lots of reinforcement for when they're implementing strategies. And I think this is what we tend to default to when we're thinking about parent support and any type of family coaching or training. But we want to be mindful of all of these different other stages are just as critical to prepare the families for change. And then finally, once they have that skill down solid, whether it be that they are implementing choice boards and using visual strategies, or if it's me, I'm running, you know, three miles 5 days a week, then we're in maintenance. And this is where we want to maintain those skills. We want to identify ways that they can continue to use those strategies to prevent relapse. So this is really lovely. We could think about this, you know, great way to increase progress. But we also have to remember that relapse happens and that's natural. That's actually a really important learning opportunity. And so it's not static. It's not necessarily just this beautiful cycle. We can bounce around between each of these And we want to make sure that when a family does relapse, maybe they forgot the visuals at home. I skipped my run day. Doesn't mean that they're a failure and they shouldn't necessarily be giving up. That's an opportunity for them to realize that nobody's perfect. There are going to be times when you implement everything as designed, and there's going to be days when you don't, and that's okay. There's no shame, there's no blame. It's just, how do we rebound? How do we recover? How do we change what we have been working towards? Maybe we have smaller steps, we have more reinforcement, but it's important to learn from those opportunities and keep things going. So this is how we can really assess where a family is at some of the different skills we want to implement with them to support them, and taking that more compassionate approach to, oh, they just can't do these things, they're not PBS ready. It's maybe they are based on the skill that we're asking them to do, and we need to identify what is going to be potentially triggering for them and coaching them through how to move through this model. And we can do that by using motivational interviewing. This is how we can show compassion and ensure that we are aligning our interventions with the values, the goals, and the overall readiness of the families. So motivational interviewing, or MI, is a collaborative approach. It's a goal-oriented conversation that aims to strengthen a person's motivation and their commitment to change. So when we're working with a parent of an autistic child, we want to identify their goals and their values related to their child's behaviors of concern or areas of need, as well as understanding their own trauma and how that may potentially be barriers or blocks for them to engage with the work that we're doing. And it's important to, again, approach this with a very compassionate approach. It talks a lot about using active listening and focusing on the parent's perspective. So really taking a non-judgmental approach and creating that atmosphere from the get-go by establishing rapport and trust. Throughout the motivational interviewing, you're going to be asking open-ended questions to, again, understand their perspective, their idea of potentially why the behaviors of concern are happening, but also how it impacts their family, how it impacts their quality of life, and how it's really setting the stage as a barrier for them to achieve their goals. And then understanding what those goals are, what does a good day look like? What are their hopes for their child? What would they be able to accomplish if these behaviors weren't happening? While we're asking these questions, we want to use reflective listening. We want to be nodding, using those nonverbal cues, paraphrasing, repeating things back to them. And really our aim is to elicit what's called change talk. So we want to ask about, well, what would be different if things could improve? What's that first step we could take? It doesn't have to be like, we don't have to be perfect. What's that first small change that we can make towards this goal? We may come across feelings of ambivalence where they don't know, they're not sure. So you want to unpick that as much as possible without pushing too much. Really using some feeling statements to make sure that it's okay if they're feeling like helpless, if they're feeling frustrated, if they're feeling angry. We want to repeat that back to them so that, again, they know it's safe and it's okay to express those feelings with us. And overall, our aim is to really, over time, strengthen that commitment to change and develop a plan. Another way to think about motivational interviewing was a really nice acronym that I found in an article by Paul et al. And the acronym is called OARS. So it's leading with open questioning. So help me understand your child's behavior. How would you like things to be different? What are some good things and what are some less good things? So asking those open-ended questions allow the family to tell their story in their own words without leading them. And this is where they can start to explore their feelings of fear, whatever trauma experience they may have had in the past that has been maybe a barrier to them engaging with other providers, and feeling comfortable talking about that and identifying, maybe they're not ready to work towards going out into the community just yet, but just, going through and changing their daily routines in their home and improving that might be a good first step. So it's really finding how much can we expect of the family and what's going to be too much throughout these open-ended questions. While we're doing this, we're providing constant affirmation. So saying things like, I really appreciate that you're willing to meet with me today. You're clearly, really compassionate, you're really loving parent. I can see that you really want your child to improve. And so just be really grateful that they're engaging with you. continuing to use reflective listening. Within that, you could be repeating and rephrasing, you could be paraphrasing, and again, like we talked about, reflecting their feelings as well. And then you also want to be just doing some type of summary reflection. This is a nice time that you can do either at the end of a conversation when you're time to wrap up, but also at a transition point. If you feel like a family is moving from pre-contemplation, you've talked about some of the reasons why they don't want to do X, Y, and Z, and some of the potential risks, and that they're starting to think about, well, actually, maybe there's some benefits. And so you might summarize, well, these are some of the risks. Are you ready to start to talk about some of the benefits now? Are they ready to move into pre-contemplation and think about then eventually moving into planning? So motivational interviewing is honestly, it could be a talk in of itself. I'm trying to just do as many highlights as possible of how you can gain some insights into it. But I really liked, again, that's Hall and colleagues' paper. Not only do they talk about ORs and how you can use motivational interviewing through those open-ended questions, affirmations, and reflections, and summarizing statements, but you can also relate it back to where a family is within that model of change. So these are the different stages that we talked about within that trans-theoretical model of behavior change. And these are some different ways that we can try to move a family through it. Again, being mindful of their own feelings of inadequacy, fear, however their trauma is manifesting, whatever symptoms they have, not pushing them too far, but constantly trying to see if we can nudge them towards the direction of making choices to change. So if they're not ready yet, here we could be talking about some of the risks. When they're starting to get ready in their contemplation stage, this is where we're talking about pros and cons, reasons for change. Again, trying to identify the why and linking it back to their own values, their own hopes, their own goals. Within preparation and action, here we're setting goals. We're helping them to not only develop that plan, but implement the plan. We're modeling it, we're coaching. Within maintenance, we're helping to fade out our support to make sure they can sustain change without needing us. And then again, we talked about already relapse as a learning opportunity. We want to normalize it and have people, again, not feel ashamed and have them not give up, but learn how they can engage in reflective practice and a shift, maybe change your plan and try again. Within the context of this, so now that we are, whether we're talking about making a plan, talking about what the plan is going to entail, one thing that you can start to use is through acceptance and commitment therapy is called choice points. This is a way to help identify old patterns of behavior of how families historically responded to a difficult situation, as well as some goals and some new patterns of behavior that are going to help them move towards their goals. So within this, we would identify what's the difficult situation? What is it that makes you feel really, really anxious? Is it taking your child out to the stores because in the past there was a really big incident that was scary and somebody potentially got hurt? So we want to define that. We want to define what the situation is, in addition to what the parents' thoughts and their feelings are as well, so we can start to unpick that. And within acceptance and commitment therapy, it's all about being okay with those negative thoughts and feelings, naming them, and then working towards moving away from those old patterns of behavior. So within that, we would be identifying what are those old behaviors. In the past, when you were trying to cook dinner and your child came in and started to grab things, did you yell? Did you hit out at them? Did you give up? Did you call for your husband to come and help because he's in the other room and you're at your wit's end and it's just really overwhelming, and then it kind of resulted in everybody in tears? Well, maybe your goal is to become a more patient mom, which seems like a potentially a silly goal, but that's an important one. So what are our move towards goals? What are the behaviors that you can engage in that's going to help you achieve that long-term goal? So is it, when your child comes in, you pause, you put things away so that way you're feeling safe. Maybe we engage in some mindfulness. You take a few deep breaths and then you ask them what they need. Maybe you call for your husband before you get upset. Whatever, those behaviors are, they're going to help them cope with that difficult situation and follow what it is that we're recommending within our behavior support plan. But it's really working towards this and mapping it out for a family when they're ready to, when they're in that planning stage or in their action stage, to help for them to see how their old patterns of behavior can shift. And it doesn't have to be the end goal that they are this perfect idealistic parent. It's what are those baby steps that they can take to move towards this goal. And that's where shaping comes in. You know, we can have the same goal. We can say, I want my child to brush their teeth for 2 minutes, and it can result in tears and honestly, potentially more trauma. Or we can shape approximations. And we do this with, you know, our clients as well as with our families. We don't have to start with perfect right away. And by shaping approximations, what we're doing for the family with the trauma history is we're gradually exposing them to things that could be triggering, but we're building up their resilience. We're reinforcing them for tolerating these, for engaging in their own coping strategies. And so, you know, for example, we can have it be the very first thing that we have as our first goal to brush our teeth is just go into the bathroom before you go to bed. Just pop in. Maybe then you pick up a toothbrush and then you just put it down, you go on your merry way. You know, we're really good at behavior analysts of breaking these skills down. And we should do that not just with our clients, but also from the frame point of what's going to be potentially the most successful for the family. What's the point of where it's going to be too difficult. And we talk a lot about pick your battles, right? And we want to be able to do that with our families and give them that way to opt out and promote those reasonable expectations so that they can have them on themselves and on their children. Along those lines, we tend to avoid any type of extinction procedures, and instead we change families' expectations, and we want them to learn more about what assent looks like with their child and what assent withdrawal looks like. And that's going to empower them to learn how to teach their child to self-advocate. They're going to learn how to reassess motivation, make environmental changes versus things like following through and teaching compliance. And this is going to make families hopefully feel less shame or less guilt by not having their child brush their teeth because other children brush their teeth. So why shouldn't their child? That's okay. Maybe the last time that happened, you know, it resulted in such a you know, intense behavior that, you know, somebody had to go to hospital or somebody had a broken bone from that. And so that's a traumatic experience potentially that we don't need to relive. We can figure out other ways for our clients to opt out and for our families to pick their battles. If nothing else, what the research shows is that unfortunately, parents of children with autism and learning disabilities rarely take time to care for themselves. And I think it's critical for us to promote self-care within our families. So we do this a lot with our clients. We work on mindfulness. We build in these daily opportunities for them to engage in mindfulness. But do we do that with the families? And actually, this was years ago. I was working with a mom and her 3 sons. They were, I think they were 11, 13, and 26. The younger two had diagnosis of autism. The eldest had autism and Down syndrome, and he had a lot of behaviors of concern both at home and in the community. And the younger two would act out a lot. So just in general, it could be feel like a chaotic family to the mom's perspective. She had depression. She had a hard time sometimes getting out of bed, let alone engaging with us and, you know, implementing some of our strategies. And when we worked with her children, though, we did a lot of zones of regulation, having them understand their emotions and their feelings and engage in different self-care strategies like breathing and things. And I remember coming in to check on them. I would come in typically once a week to work with the parent themselves and work on different strategies. And she started laughing and she said, well, I lost my temper the other day. And I said, well, what happened? Tell me about it. And she, you know, talked about what the kids were doing. And she said she started to yell. And the middle boy said, Mom, why aren't you taking your deep breaths? And she's literally stopped and laughed. And she's like, you're right. You know, she's encouraging her children to do these things and to take care of their own well-being, but she wasn't doing it for herself. And so she started to actually embed those same techniques that we were teaching her children. She started to do those. And research does show that if nothing else, if you teach a family to engage in mindfulness exercises, it's going to benefit them. And some of the families not only saw benefits to their own, you know, parenting and well-being, but they wanted to continue those strategies even after the intervention ended. So the final section that we're going to talk about today are some just meaningful outcomes. We already highlighted this earlier on, but when we think about exposure to a potentially traumatic event, based on where our starting point is, if we already have high post-traumatic stress and it's chronic, we might continue down that pathway. However, there is research that shows that people, even who start from a high, experience of stress, if they have the right supports around them and they're reinforced for coping and they're building up their resilience, they may actually decrease in their stress and their trauma symptoms over time, and their resilience may increase. That isn't always the case. It's really based on the support around them. So some people who have a traumatic event may over time increase their traumatic stress, but we have the ability to support families and build their resilience. And that's why we want to support things like mindfulness, understanding their values and their goals, doing shaping procedures to meet families where they're at. And we can incorporate all of these different strategies to help build resilience in what we call post-traumatic growth. So it's really focusing on those good days, doing those positive affirmations and reinforcing those opportunities, setting reasonable expectations that the families can achieve, providing well-being check-ins for the parents as well as for their clients, of course, doing our reflective practice, but also promoting mindfulness. It's really important not only for us to be able to support the family, but for them to identify other social supports and activating a broader network. So I will open it up to questions, but first I thought you might like to see some of the data that we have as far as how we support families and the outcomes we've seen. The first is a case study. So we were supporting a 20-year-old female, we'll just call her E. She had a diagnosis of a learning disability and a history of panic attacks. The family also had a history of domestic violence, and E was referred to us because prior to us being involved, she had 5 suicide attempts within a 6-month period. In addition, she engaged in behaviors of concern, including self-injury behavior, aggression to others, and property destruction. So you can think about, just if you're E's parent, the level of trauma that you've experienced, having a child with learning disabilities, having lived through domestic violence, having your daughter attempt suicide multiple times, and then living in this, home of destruction and aggression and self-harm. So the support we provided, we did a functional behavior assessment, but we also did motivational interviewing. We wanted to understand the goals and values of E along with her family. So her mom and her sister engaged with our service. And this was what we used to guide the delivery of our support. So we produced a behavior support plan to address her self-injury, aggression, and property destruction. We developed a crisis response plan to address her suicide attempts. But then we also had individualized parent training. This focused on readiness for the mom to support, increasing her feelings around her own well-being, and how she can learn how to respond effectively to ease behaviors of concern, really being able to openly talk about her suicide ideation and her suicide attempts. Mother was also supported in ways to communicate with her around her behaviors of concern. And we showed how to do this through modeling post-incident debriefs during our sessions with the client and the mother together. So we did a bit of behavioral skills training and some modeling. And during this, E reported that parent support was really important to her. So E wanted her mom to get support. She expressed that she was worried about her mom's well-being and she wanted her to have her own support. In addition to supporting E's mom, we engaged in mediator training. So we provide training to support workers, college teachers in implementing the behavior support plan and the crisis response plan. And then when we were ready to kind of wrap up our input, we also made a referral for the mom to continue to access support because E needed some education around sexual health. And we knew that mom would have to answer a lot of those questions. And so we wanted her to have some follow-up coaching that was kind of outside of our remit and outside of our scope. So as we think about our outcomes, we had 4 goals that we set for E and her family. One of them was around parent training. And so at the beginning of our input, we asked the mom to rate on a scale of 0 to 10, how close are you to being able to support your daughter to, implement these different strategies around her crisis response plan, around her behavior plan? How are you feeling about managing her communication? And she rated herself as a 0 at the onset. Halfway through our intervention, you can see that her goals score increased to a 4 out of 10. And by the time we closed our support, she rated herself at a 6 out of 10. In addition, we saw a dramatic decrease in E's suicide attempts and need for emergency services. So you can see there were a total of 5 attempts before we started, each which resulted in emergency services being called. During our support, there were 2 attempts. One needed a call with emergency services. This happened concurrently with a change in school. So we were helping her to access college, which was pretty stressful for E. And also the person who had been violent in their past started to try to make contact with the family again. So there were lots of setting events and triggers. But you can see we were able to sustain several months without any attempts after that. And this is the part that I really care the most about, is the family feedback. So after our input, the sister shared that it was really the individual sessions with their mom that helped her understand E a lot better. She thought that mom felt more comfortable and that E was more comfortable expressing herself to her as well. And the mom shared that she was dealing with it all on her own. It really helped to have somebody who helped E feel calmer. Every week that we came, that they felt that they could tell us their problems and we were able to give advice. She felt that E learned how to express herself and that she could now tell her anything, whereas before she wouldn't tell her anything at all. Now mom felt that she could understand E. E was expressing herself, which made her feel better, and she wasn't exploding as much. So it's nice to hear that mom just felt empowered. And then finally, we do use that Sheffield Learning Disabilities Outcome Measure as an outcome. So that's the SLDOM. We have data for 100 clients that we've supported between 2020 and 2023. So for the SLDOM, it's a score out of 0, it's a score out of 40. So this is where we report pre-intervention. So before we start to do any type of work with the family, we complete the assessment. We do it at the close, and then we do a 6-month follow-up check-in. So while the scores don't look like they're moving too much, if you do a percentage, before we're involved, it's usually about 64% confidence that a family is able to support their child, understand their behaviors of concern, and that they, it talks about like feelings of inadequacy related to their behavior and their own coping skills. At the close of our service, it's usually about an 80% score. And then it's lovely to see that the success continues. So after we close, it's about an average of 85% that families have as far as a score goes in the SLDOM. So just to summarize, while we do need to prioritize our client and their needs, we can't neglect the experience of the parent and their own trauma history. As behavior analysts and PBS practitioners, we have the tools to use motivational interviewing, shaping, acceptance and commitment therapy-based strategies to engage parents. And positive outcomes include both changes in client behavior, but also mediator confidence in implementing strategies. For those of you who are looking for CEUs, the sign-out code is Woody. Think of Toy Story. And then if you have not already, we do hope you enjoyed today's presentation. Just as a reminder, this was a free event for everybody, which was so generous that a lot of work had gone into prepping this event and hosting it. So thank you to everybody who was involved. And the ask is, if you are comfortable and able to show your support, the Newman Holiday Trust is an amazing opportunity for children to access life-changing opportunities to develop friendships, work on social skills, that also allows the families and their carers opportunities to take a break. So it gives a bit of respite. And this is a really nice summary. This is right from their website. Even just £5 can be a gift for a child. £50 you can pay for a group of 25 to do horse riding, all the way up to a whole holiday. So there is a link available, and the event is doing a total contribution, which could be really life-changing for some families. There are numerous references available because I am a nerd, and there's an opportunity for questions if anybody has any.
Fabulous. Thank you so much, Susan. That was immeasurably brilliant. To be completely honest, Sandra and I have been making so many notes. Some really sort of practical advice. But also, I think it's really conceptualized some of the stuff that we've already been doing in some ways, which has been quite reassuring. But definitely some real good tips and tricks that we can sort of take away, and some tools we're already using, but some new ones as well. So we have got some questions, which we'll try and let's get through as many of as possible. We've got 3 at present, and they're really good questions, but we'll have to draw to a close sort of promptly-ish. But
I think we have another couple of minutes. Yeah.
yes. So the first one that came in was on the why of trauma assessment measures. What might you say to a view that assessing and intervening with the parental trauma is working beyond the scope of competence principle for behaviour analysts?
Yeah, I think that it's really important to think about trauma as a motivating operation and a setting event for families to either engage or not engage with our recommendations and our services. And it's part of our ethics code is that we support everybody around the child, right? And or the individual. And we know through our environmental analysis that these individuals don't live in a vacuum, and assessing their interpersonal relationships and their environment is critical. So physical environment, interpersonal environment, programmatic environment, that's usually where our recommendations come from when we think about behavior change. And if a family isn't ready to access that, we may say, oh, they're not PBS ready and move on to the next family. Or we can say, why aren't they ready? What's going on in their lives? How can I tailor my support to meet them, to meet their needs?
Yeah, absolutely. It links in with contextual fit, doesn't it, as well, in making sure that what you're
Exactly.
doing.
And the new task list has compassion in it. So hopefully that hopefully sways people. And if you're feeling that it's outside of your scope, then get supervision. So, do some courses on acceptance and commitment therapy, do some training and motivational interview, and have somebody who can support you through that.
Yeah, fantastic. And yeah, agreed. We use ACT in some of our approaches, and similarly, we've done ACT courses, but actually, in many ways, find it applies just as much to the families as it does to the supported.
It definitely does.
And again, a few people in the chat sort of saying it's really nice to see sort of ACT, Russ Harris's choice point, and those sorts of things. But so someone specifically in relation to the mindfulness has asked, what are some of the mindfulness brief intervention exercises for families that do not subscribe to mindfulness?
Yeah, I think it's really, this is funny. I think it's really identifying what's going to help that family cope. There's only one time in my life when I've told somebody to go and take a smoke break, and it was a parent who looked like they were about to cry because their child was really having a meltdown and she wanted to help, but she knew it was too much for her. And I had to say, like, I got this. It's okay. Step outside, take a smoke break. Do I want her to be smoking cigarettes? No. Was that her coping strategy in the moment? Yes. Did it help alleviate everything? Even just even stepping outside and taking a break. And so it's really asking the family, when are the times in your day that you feel the most calm? When are you the most relaxed? Is it drinking your morning coffee? What's going on? Is it quiet? What's the environment? I know there was a talk earlier about, sensory aspects of trauma. It's like also doing a sensory assessment around the family. I call it mini moments of joy, and how can we increase those for not only our clients, but for our families as well. And that's where I would. So not everybody is taking 5 deep breaths. It's really looking at what's going to help them regulate. Sometimes it's going for a run, cigarette break, not ideal, coffee, whatever works for them.
Oh, brilliant. Yeah, that's a great answer. Thanks so much, Susan. Sort of a quite specific one here, but I don't know if you can answer this one briefly, but we'll give it a go. What strategies would you use with a single mother that is at risk of child protection involvement to take her autistic child away? Domestic violence history, plus alcohol or drug use to cope with the child's behaviour as well.
Yeah, I'd be activating the network. So a broad answer is I've
Yeah.
had to work with those families before, and you can't do it on your own. You need to get respite care. You need to get, education involved. You need to have social work involved. You need to have school involved. She needs to see that there's a team around her that's supporting her and empowering her to hopefully stay with her child. And then if that's not the right time for her or her child, how do you work to getting that family back together again?
Yes. Yeah. Right. Yeah, exactly. That's really good broad advice. Thanks, Susan.
Of course. Yeah, I wish I could give you more specific. But yeah.
Um, there's your contact details.
Yes, exactly. So there's the contact details, shameless plug, we are hiring, but that's me. If you have any more questions, that's our company website. And if you are interested, that's where you can send your CV.
Oh, that's really useful. Thank you, Susan.
Thank you.
And just to, slides and video recordings and hope those sorts of things are going to be available, hopefully, sort of after the event. So someone's asked about the reference list, that will be available there. You'll be able to sort of look back at it.
100% it will be, yes.
CEUs, just in case anybody, I might just unshare you if that's right. A second,
Yes.
Susan, and share the QR code. So CEUs, there is a link which I'll put in the chat, which might be a little bit easier for some people. But I will also show you the, thank you, Sandra, I was about to show you the wrong thing. This is a QR code to access the, no, that, hang on. This is a QR code. Yeah, there we go. To access the page that you need to enter your keywords into. So we want the 2 keywords, which were both Disney characters, followed by your email address, not Tia's email address, which is there, but your email address, so that we're able to get those CUs over to you. The quantity is £8, so that's what you type into. We have had it, it's a little slow when everyone is doing it at once. So if it doesn't work immediately when you do it, then it might be worth just trying again a little bit later on, or perhaps tomorrow. It's just I think it's been a bit overwhelmed by the amount of people that have been using it today. So so that's there. And yeah, thanks so much for the Newman Trust slide as well. That's really useful, just to get that into people's minds. The number is gradually increasing as the day's going on, so fingers crossed we'll have a good amount to share with them. I think that's everything, isn't it? Thank you so much, Susan. That's been really, really useful. And we really appreciate you giving the time to come and present for us today. So yeah, huge thanks. Our next talk, if anyone's coming to it, is at 2:30, which is the keynote, on a different Zoom link. So I might see some of you folks there. But thank you very much, everybody.
Thank you, Susan.
Thank
you very much. Have a great rest of your conference.
Thank you. Bye, everybody.
Bye.